Now, during his State of the Province address, Gauteng Premier Panyaza Lesufi said the provincial government was working towards clearing surgical backlogs. Lesufi said since last year on Mandela Day, the backlogs have been reduced from 37,000 to just under 12,000. I am joined now by Motalatale Modiba, spokesperson for the Gauteng Department of Health. Motalatale, thank you so much for joining us this evening at News at Prime. Now, Premier Panyaza Lesufi called it a war on surgical backlog. This entailed marathon surgeries, and so far about 25,000 surgeries have been done. Can you explain this initiative and what do marathon surgeries look like, if you could paint that picture?
Thank you, Martha. Indeed, it has been quite a feat in terms of the kind of backlog that we were dealing with. You'd recall that in July last year, during Mandela Day, the department under the leadership of MEC Nomantunko Morale Hoko announced an ambitious program to say part of the commitments or targets that the Premier had set for the MEC was to eradicate the long-standing backlog that we have always had, which has actually been a challenge in terms of addressing. So the team, a team was put together, a project team, to actually work on this project, and that team comprised of specialists, nurses, and other workers across all our service platforms. And we had to make sure that part of the interventions was to make sure that the theaters that we needed to operate are actually brought online, and we have as many theaters as possible operational. So the backlog actually, as I talk to you now, has actually even reduced further because remember, even this month we are currently running the surgical marathons, but focusing on patients that are who had undergone ostomy surgery, and we have to obviously do what is called the colostomy closure to ensure that we restore the normal flow of their waste through the digestive system. So that is what we're focusing on. So we've been on during this week when we were looking at the updated stats. The backlog is currently sitting at around 7,000, I think 7,500, just above 7,000. So it has actually moved even from the time when the Premier announced the latest numbers during the State of the Province. This has taken quite a lot of effort in terms of the multidisciplinary teams that have been put together. But what is even more exciting is the fact that we did not have to necessarily go outside in terms of spending more money than what we would have spent currently, but we had to utilize the existing skills that we had by ensuring that they were more structured, and we deliberately scheduled this particular marathons, and targets were set for each facility. In fact, as you and I speak, the Premier has already given us a challenge to say, can we conclude the remaining backlog by end of this financial year, which means that by March 31st, we should have eradicated this historic backlog. Of course, you know, Master, that in terms of surgical backlogs, you're always dealing with a moving target because obviously as we deal with this historical backlog, you've got new people that are coming in into that require surgeries and so forth. But at least those people would not have to wait long because with the current surgical backlog, we have people that have been on the waiting list, some for 12 months, some for more than that. But through this intervention of surgical marathons, where even over the weekend, the teams are able to run this particular marathon, we've been able to see a significant reduction in terms of the backlog that we've been sitting with.
Just maybe explain to us what it entails as well, because that was a follow-up question. You know, you're saying that, you know, you didn't thankfully have to go out and get extra budgets for this to be done anyway. Tell us about those 4 different types of surgical marathons, and then these specialists that you used who were in-house already. How did that work? Does this mean that, you know, on their off time, they're coming into the hospitals and performing these surgeries as well? What kinds of sacrifices are these entailing as well?
Look, it meant that obviously we became more structured, but one of the things that when the MEC was deployed to the department, one of the things that she did was to zoom into the type of infrastructure that we had, which meant that we had in some facilities, theaters that previously were dormant and not necessarily operational. And we had to make sure that those are operationalized to ensure that we have additional capacity to be able to assist and do some of these backlogs. And in some instances, we had specialists moving from one facility to the other. For example, facilities like Charlotte Maxeke, which are highly specialized facilities and have got high, special clinicians who are highly trained, had to then be redeployed to other facilities. Like now, when we're doing the ostomy surgeries, we had some of the professors there going into facilities like Besatwawa, assisting and ensuring that we build capacity. You would have seen even recently, we had Begimlagen, which did its first heart surgery, which previously they were not able to. But because of the continuous capacitation of our service platforms, we have seen them now also building internal capacity. If you go to Sebokeng Hospital, they performed last year their first brain surgeries. They have never done that in the 40 years of existence of that particular facility. All that is because of the continuous training and the development of platforms where we're able to allow facilities that are advanced in terms of certain capabilities to be able to work closely with those facilities that still need to develop, and by that way exchanging skills and being able to ensure that resources become available. One of the other things is that from a resource point of view, you would recall that in the past we would have challenges around linen availability and all of those things. So we had to then make sure that even from a supply chain point of view, that there is adequate linen that is available across our facilities. The use of working tools and medicine, that had to also be looked into to ensure that this supply chain is able to come on board. And I'm happy that, during this period, since we started, we've never had a situation where we've had to cancel because we don't have consumables at our facilities. So those are some of the things that had to be looked at. And even now, when we were looking at some of the lessons, and we were saying we need to be able to sustain this because we've seen that there is sufficient capacity within the public health system. Of course, in some instances, especially during Mandela Day, we worked quite closely with some of the private sector institutions that had also said, we want to join in. We are also pledging to be able to assist you with capacity where it's necessary, so that we don't have a situation where some of these things, surgeries are postponed because you don't have sufficient capacity. So the good thing about this is that as we speak now, we have been able to also expand the capacity from a knowledge point of view in terms of our different specialists and clinicians that are on the ground. And I think earlier on you mentioned some of the types of surgical marathons that we focused on. Of course, it's a list of things, but I think the most dominant ones in terms of the high number of patients that require surgical operations. You had cataract. We've been running marathons almost, especially at facilities like Gauteng Hospital. They've been running those almost on a weekly basis to ensure that people that require their eyesight restored, they get to have this operation done. We've done urology and general surgery, and also arthroplasty, there where people needed to, things like your joints and hip replacements that we needed to do. Those are some of the things that we needed to do. And by the way, the bulk of the people that needed operations were at the 4 central hospitals, meaning your Chrishane Bara, Charlotte Maxeke, Dr. George Mukari, and the Bigo Academic Hospital, because historically capacity has always been in those particular facilities. So now that we've built more capacity at other facilities, we are seeing facilities like OR Tambo, the Tambo Memorial Hospital, being able to now also do some of the surgical procedures, which then means that it alleviates pressure onto the central hospitals to be able to focus on maybe more complex cases.
Well, good luck with that 7,500 or so that remain. Hopefully it will be completed before the end of the financial year. And thank you so much for your time and your insights this evening.